I'm Tom Hardie, and I'm an Improvement Fellow at the Health Foundation. And we're going to talk to you today about our research on empathy, automation, and AI in healthcare. AI and automation hold vast potential for improving healthcare, but the increasing use of these technologies in patient-facing contexts could have significant implications for care delivery and patient experience. Within this, there are implications for person-centered care, and in today's session, we'll be focusing on what the increased use of tech could mean for person-centered care and where the tensions could be created. To do this, we'll be exploring a series of scenarios, such as the use of robotic care assistants and AI triage to decide which patients are prioritised for care. We'll present the findings of a recent YouGov survey, where we asked UK adults how they felt about these different scenarios, and then we'll hear the thoughts and reflections from a person with lived experience and a primary care doctor. And there'll also be time for Q&A at the end. So what are AI and automation, and how might they improve healthcare? Let's firstly take a quick look at what we mean by AI and automation. AI refers to statistical tools and algorithms that enable computers to simulate elements of human behavior, such as learning, reasoning, and classification. Automation is, in essence, the automatic execution of tasks with minimal human input. And in many cases, this will mean performing a task that a human has traditionally done. Although automation isn't anything new, recent developments in AI and robotics are extending the reach of automation beyond what was previously possible. Because of this, we're increasingly seeing the potential of technology to undertake not just manual tasks, but also cognitive tasks too, including in healthcare services. Automation and AI present a range of opportunities to improve health and healthcare. For example, giving us the ability to monitor our own health and provide personalized advice on how to stay healthy, analyzing data to help us understand unwarranted variation and how to reduce it. It's also presenting opportunities to deal with admin, like processing referral letters, managing bookings, scheduling, and other admin tasks. It could also help with image analysis, for example, to detect signs of breast cancer or eye disease. And there are also possibilities to use interactive robots to help alleviate stress and anxiety, or to provide care and support for someone at home. However, while there's a lot of excitement about AI and automation, many of their applications require further development and real-world testing to prove that they're safe and effective. After that, there'll be further work required to successfully implement them into healthcare services, which can take considerable time, effort, and resources. Over the past year, we've seen the National Health Service implement technology at impressive pace and scale, and there are calls for this to continue. But we think it's important to consider where technology should and should not be applied, which is particularly important when we think about sophisticated technologies like AI, where the risks could be higher or where human interaction could be reduced. And even if the precise scale of impact is unclear and some applications require more work, we think it makes sense to be considering these questions now. We know that making sure that healthcare is person-centered is really important and is a key contributor to good outcomes and experience for patients. But what does technology mean for person-centered care? And what does it mean for the role of the human? With the increasing use of technology, we might see computers undertake tasks normally done by humans. And while there may be benefits, there is also the risk that we might lose important elements that humans bring to healthcare. For example, when we think about person-centered care, this requires social and emotional intelligence, which is the ability to read the feelings of others and know how to respond in an appropriate way and to manage relationships. It also requires compassion and empathy, or a willingness to appreciate the patient's perspective. Person-centered care also involves the ability to treat people with dignity and respect, which is about giving people privacy when they need and want it, treating them as equals, and providing support they need to be independent. And then also, person-centered care involves strong clinician-patient relationships, which are fundamental to co-production and shared decision-making. So could technology help or hinder person-centered care? And how might this play out in practice? We'll now explore 4 scenarios to see what the increased use of technology could mean for person-centered care.
Hello, my name's Tim Horton. I'm an Assistant Director at the Health Foundation, and I've been working with Tom on this project. So to explore what impact automation and AI and other technology might have on empathy and person-centered care, we looked at 4 scenarios with applications of technology that are either with us today or might be with us in the near future. Self-checking, delivering bad news by video link, AI triage, and robotic care assistance. Each of them presenting interesting, at times deep questions, which I'll describe in a moment. We worked with the polling company YouGov at the end of 2020 to ask over 4,000 UK adults about their thoughts and feelings towards these 4 different uses of technology. And we asked people for their views on these uses of technology in principle, specifically on how they might impact on person-centeredness. And we also asked whether they personally would be comfortable using technologies in this way. Now, we expected a variety of things to affect people's views. Each technology will, of course, have its own perceived advantages and disadvantages for the healthcare situation in question. This includes the potential impact on the human dimension of care and how people might weigh this up against potential advantages of technologies like faster speed or increased convenience. So in particular, we think the following 2 questions are particularly important here. How important is human interaction or emotional intelligence in the task? And how badly might the use of technology undermine possibilities for human interaction or emotional intelligence? So, for example, on the first of those, people might think emotional intelligence is more important for, say, communicating bad news than for checking a patient in. On the second, they might think communicating by video link actually might not undermine possibilities for human interaction as much as, say, robotic care assistance. Alongside this, we think there are some other factors that will come into play that we've illustrated here, such as how familiar are people with the technology and the use of the technology. For example, most people would be familiar with touchscreen check-in, less so with robotic care assistance. Secondly, the usability of the technology. And thirdly, the risks associated with the healthcare situation. For example, there might be more risks to getting triage wrong than checking them. So we think all of these things are potentially going to affect these uses of technology and the attitudes towards them. So let's have a look at the scenarios in detail. First, self-checking, check-in through a computer touchscreen rather than with a receptionist. Now, we're seeing automated systems potentially now able to perform a range of tasks that have traditionally been carried out by a GP receptionist, such as check-in or appointment booking. And as well as freeing up receptionists for other tasks, the use of technologies like this could offer benefits for patients, such as greater privacy. On the other hand, patients may value interacting with a receptionist, and there may be a variety of benefits to this, such as allowing the receptionist to get to know patient needs. In a research project by the University of Oxford that the Health Foundation recently supported, looking at automation in primary care, the field researchers noticed that in GP surgeries, patients would often bypass touchscreen check-in specifically to go and speak to the receptionist, ask them questions, and say hello. So what might be the negative consequences of reducing face-to-face contact in the GP surgery reception through technologies such as touchscreen check-in? And do these outweigh the benefits that systems like this could offer? Well, let's have a look at what people thought. So we asked people firstly for their views in principle. As you can see, 72% said a touchscreen is better, quicker, more convenient and private, as opposed to 21% who said it's a shame if people have to check in with a touchscreen. They may prefer to speak to the receptionist instead. And that also translated through into people's feelings about their own care. 86% said they would be comfortable using a touchscreen to check in rather than speaking to a receptionist, as compared to only 10% who said they would be uncomfortable. Interestingly, people with a carer a lower proportion of them supported the touchscreen approach or said they'd feel comfortable with it, but still within the context that the overwhelming majority of them would prefer that approach. Let's go on to the next scenario. This was delivering bad news by video link. So the NHS long-term plan signalled major ambitions to expand virtual consultations. And this process has, of course, since been rapidly accelerated by the response to COVID. Now, what impact, if any, might greater use of video consultations have on empathy? We know that empathy matters for effective patient-clinician interactions. So, for example, when clinicians are empathetic, then patients tend to disclose more. But there can also be challenges with being empathetic online. Important non-verbal cues can get lost. It can be hard to make authentic eye contact if your camera isn't centered, and so on. So are there situations where virtual consultations may not be appropriate? Let's consider the case of a doctor communicating a positive cancer test result to a patient. Does empathetic care here require face-to-face contact? Is it harder to do it sensitively and compassionately by video link? Or alternatively, does it provide a better experience for the patient if they receive the news in their own home, maybe with friends or family, and don't have to face a journey back afterwards? Well, let's look at what people said. And you can see the poll results in this next slide. So 71% said this is something that should be done in person. It's easier to communicate with sensitivity, respect and compassion face to face, as compared to only 18% who said it would be better over video link. And we also saw that pattern reflected in people's views and preferences about their own care, with 60% saying they'd feel uncomfortable receiving bad news in this way compared to receiving bad news face to face, as against only 31% who said they'd feel comfortable. Here, one of the more interesting demographic splits was for older people. Of those aged 55 and over, slightly more agreed that this is something should be done in person, and slightly more than the population as a whole said they'd feel uncomfortable about receiving such news via video link rather than face to face. Let's go and look at the next scenario now, which is AI triage, using an AI computer to assess patients in A&E and decide who should be seen first. Now, data analytics and machine learning are increasingly enabling automated systems to diagnose conditions and predict risks. And this allows their use in triage, for example, in accident and emergency departments. But even though these systems can come close to and may one day exceed human performance, does it follow that they can ever replace clinicians in triage? Significant finding of social psychology in recent decades is that people can care more about the processes of decision making independently of the outcomes. For example, people who lose court cases may nevertheless feel more satisfied if they believe they've had a fair chance to have their argument heard, compared to those who feel they haven't. Now, in a similar way, is the ability to have your case heard and considered by a human clinician important for patients to feel that they've been treated with dignity and respect? Alternatively, if AI triage can lead to quicker and more consistent decision making, potentially free from certain kinds of human bias, would patients prefer that? So, in short, there are important issues of procedural fairness and acceptability concerning how decisions are made and resources allocated, where the increased use of automation and AI might have important ramifications. Let's have a look at what people thought about this scenario. So, as you can see from the slide here, 54% said it was important in triage to have your case considered by a doctor. It could feel disrespectful, uncaring, or unfair otherwise, as against 37% who said, provided such a system was as accurate as a human doctor, it's fine for a computer to determine a patient's priority for treatment. In terms of feelings regarding one's own care, opinion was more evenly divided, with broadly equal numbers saying they feel comfortable and uncomfortable about the use of AI triage. Again, this is an area where those with a carer were slightly less sold on the use of technology than the population as a whole, with 55% of those with a carer saying they would feel uncomfortable with AI triage. Let's now go on and consider the final scenario, robotic care assistants. This is using robots to support people who need help at home, including with meals, getting dressed, and going to the toilet. And as demand for social care rises, robotic technology is increasingly being seen as a viable means of assisting people who need support with daily living at home. And as the sophistication of robots is increasing, they're seen as being able to assist with tasks such as getting dressed, going to the toilet, meals, and potentially even providing an element of companionship. Now, does using robots to fulfill these functions undermine the ethos of care and support? Is it impersonal and dehumanizing, undermining dignity? Or conversely, can it strengthen dignity by giving people a greater sense of privacy and independence? Let's have a look at what people thought. So as you can see from this slide, 47% said a robotic carer risks undermining dignity. It's impersonal and dehumanizing. 31% said it could strengthen dignity, allowing greater independence and privacy. In terms of feelings regarding people's own care, we saw a similar pattern there. 48% said they'd feel uncomfortable with some of their robotic care being provided. 48% said that they would feel uncomfortable with some of their care being provided by a robotic carer rather than a human carer, as opposed to 38% who said they would be comfortable with that. The most interesting demographic split here was between men and women, where there was quite a large gender difference. In particular, women being more negative about the prospects of robotic care assistance. So in terms of feelings regarding own care, 56% of women said they'd feel uncomfortable with a robotic carer providing some of their care rather than a human carer, compared to 30% who would feel comfortable. And this balance was reversed for men, with 46% saying they would feel comfortable, as opposed to 39% saying they would be uncomfortable. Now, in this final polling slide, I've put all of the results together so we can compare them. And this allows us to draw out some key points. First, it's clear that there may be challenges with integrating some of these technologies into healthcare in a way that patients feel comfortable with. Touchscreen check-in was the only intervention that the majority of respondents were comfortable with, and the only one where a majority thought the tech approach was better. Interestingly, however, you'll see that scores for respondents' feelings towards uses of technology for their own care were consistently more positive than scores for their views about these approaches in principle. And this suggests that you didn't necessarily have to think the tech approach was better in order to feel comfortable about using it personally. Or conversely, if you thought the tech approach was worse, that didn't automatically translate into you being uncomfortable with using it for your own care. For many people it did, but it didn't do that universally. Finally, it's clear that public opinion is very diverse. Despite touchscreen check-in being the only intervention where the majority of respondents were comfortable, sizable minorities were comfortable with each intervention. And on some options, views were fairly evenly divided. So rather than attempting to generalize about what patients do or don't want, we need to find practical ways of capturing and responding to preferences. You can see on this slide those points summarized. And I guess the broader point is just the importance of more research in this area to try to understand better user views and preferences, including how they evolve over time, given that this is an area where norms are still developing. Thank you, and back to you, Tom.
So, given all of that, how can we get technology-enabled care right? And what should policymakers and people working in health and care be thinking about? Firstly, engagement with staff and patients from the beginning will be really important to understand views and preferences and inform decisions about the best ways to develop and deploy technology. Second, co-design with staff and patients again will be really important to ensure that technology is truly problem-driven and built around the needs of users. And thirdly, we have differentiation, which is about knowing when not to use technology, because there might be situations where technology doesn't work as well or is not beneficial, for example, in relation to certain conditions or groups of patients. And where tech options are appropriate, there should be alternatives for people who want or need them. And we know that choice is an important part of person-centered care. To explore these issues further, we're going to hear thoughts and reflections from Katie Clark-Day, a person with lived experience, and Bex Fisher, a primary care doctor. Over to you, Katie.
Thank you, Tom. As Tom said, my name's Katie, and I've got 25 years experience of living with multiple long-term conditions. About a decade ago, I gave up a health psychology and social work career, and alongside my wife, who has become my carer, we manage my conditions, treatments and monitoring, etc. as a full-time job alongside being parents to a toddler. The last year during lockdown, we've witnessed this rise in the use of technology and AI throughout the various touch points we have with the NHS. So this is a really interesting time for us as people who do this full time. I'm going to give some brief reflections on the scenarios and then some cross-cutting reflections as well. The checking in at the GP practice is something we're very familiar with. I think for a really long time we've had that option. It's an easy technology and not something that's going to leave people behind, and largely positive experiences of that. But inevitably, there's sometimes questions that a computer can't answer. I've turned up sometimes, don't know whether I'm supposed to see the nurse or the doctor first, or have my ECG before the appointment or afterwards, that type of thing. And I think at this point, the tech's slightly behind being able to answer some of the more unique questions. So as good and as familiar as that is, I do see its limitations, but I do appreciate what it is and where it could go, in terms of being able to not only check in but book appointments and deal with prescriptions, etc. The triage one I found incredibly interesting as somebody who was in and out of A&E quite a lot at the start of a few of my diagnoses. And I feel like this gives the opportunity for something that can hold a wealth of information and knowledge that medical professionals just can't. You can't be expected to know everything about every condition, diagnosis, treatment, symptoms, drug interactions. So it has the potential for me personally to make the process quicker and safer and more efficient. However, I do worry about the subtleties of some symptoms, the non-verbal cues that people pick up on, and also some of the questions that you might have that help you understand how to explain what's going on with you, if that makes sense. Questions like how much pain are you in and what does the pain feel like? I think people take as much from your physical actions as they do from your answers in questions like that. And for me, quite often presenting at A&E very exhausted and emotional after days of trying to managing symptoms, it's good for me to see a person and know that there's somebody there who cares and is going to try and make things better. But potentially for me as well, there's a positive in my head that an AI approach could mean that the individual I get to see has more time to spend with me and see what's going on, because some of the other administrative tasks and triaging processes have been done without that person having to put their back to me and look at a computer screen. Delivering bad news via video link. I have had bad news delivered to me multiple times, obviously over the course of such a long time. And in my experience, both have the potential to be necessary, both a face-to-face approach and an AI approach. There have been times when I've had a bad diagnosis or bad news that I've just wanted to get out of that room and go home. And not only can't you just get up and run away, you've also got to navigate the paying for your car parking and drive home and just the whole thing. Whereas if you're at home, you're much more in control. And on the couple of occasions that I've had bad news via a telephone call, actually I feel like I've been more prepared and more able to ask the questions I need to ask as well, because I feel like I'm put a little bit more on the back foot when I'm there in person. I think it's really appropriate that people know when they're going to be having a conversation with a doctor that, for example, you will be receiving test results in this consultation, or we will be discussing your prognosis in this conversation, so that people can make that decision, because people need to have a choice about how this works. Robotic care assistants, I feel like I'm less able to comment because it still feels very much like science fiction to me, and well beyond the pace that I'm feeling comfortable with technology advancing. However, as somebody who did have a close family member receiving in-home personal care for a long time, I do feel that she would have found it more private, less invasive, and made her feel more comfortable. However, as a family member, I would have been worried about an increased risk of injury to her, a risk of falls, a risk of choking when food was being dealt with, and how that technology would handle an emergency situation like that. So I do feel when we're talking about decisions in that regard, perhaps family members need to be involved in how these things advance as well. And then, so summarising overall, I do feel like artificial intelligence and other technology will never replace the human interaction required in healthcare, because that requires a trust and a relationship that you just can't have with a machine, I don't believe. But I do feel like it could enhance the experience and make it a more efficient, safer experience, so that these human interactions can be better and can be focused on what they need to be focused on. My second point is I really feel like any AI or tech approach that's designed doesn't need to be, you're not designing that piece of technology or that interaction, you're designing it in a whole context of which it's going to be delivered and sit within. So you need to be talking to the patients that are going to be using it, but you also need to be talking to the doctors, receptionists, the nurses, the doctors, everyone who would normally interface with in that situation, because they'll tell you if it will work before you start designing it, and they'll tell you how it needs to work. It just needs to be done always in consultation with all the people involved, and that's, as a patient, that's, I'll always shout from the rooftops that patients need to be involved, but I really believe that the healthcare professionals do too. And ultimately, my third point is that it's about choice. We want to be able to access and utilise the positive uses of AI. Of course we do, for those of us who it's a full-time job for, and also the people who have very few touch points, people who very rarely go to the doctors. Let's make it easy for them to go and not think, oh, it's just a mole, I'll ignore it for now. The number of people I've seen diagnosed with skin cancer during the pandemic because they could just send a quick email of a photograph, and they wouldn't have done necessarily because they were working and not working from home previously. It has, like I said, it's got an opportunity here to make it safer and quicker and easier for us, but it's got to be done on the basis of choice. People need to be able to choose whether it works for them, and I believe that the physicians and whoever's on the other side of that needs to decide whether it works for them as well, because if they're uncomfortable with it, the patients are going to feel that discomfort as well. So they're my reflections. Pass on to Bex.
Katie, thank you. My name's Bex Fisher. I'm a Senior Policy Fellow at the Foundation, but I'm also a general practitioner or primary care physician, depending on where in the world you're tuning into this from. I'll keep my comments fairly quick because I'm pretty sure there'll be lots of questions. There were just three things I wanted to reflect on briefly based on what you said, Tim and Tom. One was just an observation on the survey data, which may be right or wrong, you can correct me. And then just some thoughts about equity in AI, and also my perspective as a GP, picking up on Katie's last point there. So just with the scenarios you presented, I was really interested to see that with the self-check-in, people who received care were less keen on it. With the breaking bad news over video, older people were less keen. With AI triage, again, people who are in receipt of care were less keen. And I just wondered, so is it then the case that people who actually use or who are more likely to use healthcare are less okay with scenarios? Is there a kind of gap between what we think would be okay if we're in the abstract of the situation and what we actually want when we are having care ourselves? I don't know the answer to that. I was just really interested looking at the numbers in your slides. I think related to that is a broader point I would like to make about equity in healthcare and some concerns that I particularly have about AI and tech. And I guess this comes off the back of being a doctor in an area of high deprivation, working through a pandemic where all of a sudden our front door couldn't be open in the way that it always has been. And we were having to rely on our patients having access to phones or internet, data, Wi-Fi to be able to contact us, and some real worries that many of us have had about how that affects who can access care and, really importantly, who can't. As if automation and AI in healthcare are going to be patient-centered, then they should work for all patients. And my question is, do they? And we know that not everybody is equally digitally literate. I think NHS Digital suggests that something like 20% of the UK population don't have basic digital skills, or in fact engage with digital technology at all. And that's a pretty significant chunk. And you're more likely to be digitally excluded, not by chance, but by social patterning. So certain groups of the population, people who experience socioeconomic deprivation, people who don't have English as a first language, people who are older, lower income, are less likely to be digitally included. And so I guess a concern that I have is that we have a lot of inequity in our healthcare landscape at the moment. We have a lot, there is a difference between where need is and where healthcare provision is. And I worry that we're going to reinscribe that inequity onto digital and virtual landscapes unless we really, really build in equity to the tech that we're developing. And I suppose, just as a little example of that, if you have an AI algorithm that is based on who is using the algorithm, then how good is that algorithm going to be when it comes across somebody whose data isn't usually being inputted into that? And is that going to make their care worse? Do we end up with health systems that cater to wealthy people who are aged between 20 and 60 who live in more affluent areas? I don't know, and that's probably hyperbolic, but I think that's a concern. And finally, just some thoughts on what it's like as a doctor, I guess, and this builds on Katie's last point. Clearly, how patients engage with, experience and access our health system is the number one concern. But we do need staff to want to work within these systems. And I think a lot of my medical colleagues have had, and I would include myself in this, a bit of a kind of sense of a professional identity crisis in the shift how we deliver care. Because lots of us trained to these roles, and I imagine this goes far beyond people who are doctors, because we care, because we enjoy working with people and getting interaction with people, feedback from people. My personal experience is that it is not the same doing that down a video camera as it is doing that in person. And I would be so interested to see the answer to your survey questions if you'd asked a group of healthcare professionals how they feel about breaking bad news to a patient over a video. I don't know what the answers would be, and I think maybe it's a nice point to conclude to say that I would echo Katie's final point, which is this has to work for patients. To make it work for patients, it has to work for healthcare professionals as well, because ultimately we are working together with the same shared goal. And I'll leave it there and pass back to you guys to field, but I'm sure will be some really interesting questions on this.
Thanks so much, Katie and Bex. I think really insightful and thought-provoking comments there. I think, highlighting how technology could make care better, but how this will depend on the situation, how it's designed and delivered. It will also depend, of course, on personal preference. The equity point is really important, and digital inclusion is clearly a big issue that needs to be addressed. And as Beck said, we have to look at how technology will impact on the work and the roles of healthcare professionals. So considering what will be required to make sure that these technologies work really well for patients, but also really well for healthcare professionals, to make sure that the impact is a positive one for all those people involved. And I think this kind of takes us back to our three key takeaways, just demonstrating that clearly engagement from the beginning with a really wide range of patients and also a wide range of staff will be important. Co-designing solutions with those different groups of people, and also making sure that the options that are available or made available are specific and tailored to the people using them, and making sure that, as Katie said, patients are able to have choice and are able to exercise their personal preferences. And we're looking forward to hearing your questions in the Q&A in just a moment. Before we do that, I just wanted to quickly mention some of the work or other work from the Health Foundation. So if you've been interested in the themes today and you'd like to read more, then you can go and take a look at our recent reports on the adoption and spread of innovation, on the learning from our experience of using technology in the National Health Service during COVID-19, and another report on key factors for successful health tech implementation. And on the far right-hand side, we'll be publishing a report on AI and automation later this month, so keep an eye out for that. And you can find out more by visiting our website, health.org.uk. And now back to Catherine, who's going to be chairing a Q&A session.